Le damos la bienvenida nuevamente al doctor Davinder, que por segunda vez nos va a dar una presentación. La primera fue de GAT, que estuvo excelente, y ahora nos va a hablar acerca de técnicas innovativas en glaucoma, así como también revisiones de trabeculectomías ya fallidas por AVE interno, o sea, sin abrir la conjuntiva, sino entrando por cámara anterior, entrar por la esclerectomía y resolverlas de esa forma. Entonces son innovaciones en glaucoma y más. Thank you very much for your presentation, Davinder. Again, thank you very much for participating, and welcome again to these webinars. Thanks, my friend.
Thank you, Juan Carlos. It's a pleasure to be back with everybody and to have this opportunity to have another exchange during these crazy times. Today, I'm just going to talk about some ideas we've had here over the past maybe 10 years now on ways of trying to make glaucoma surgery maybe better and safer. Again, with the thinking of making this better and safer in a cost-effective way. These are my disclosures, again, none of which I think are pertinent to anything we're going to talk about today. You know, we're all kind of trying to make light of this coronavirus, and this is one of my, you know, the comics are coming out, and it's a great opportunity to have a moment in spite of all this to laugh. So, you know, who thought the coronavirus could do what no woman has been able to do, which was stop all sports, shut down bars, and keep all the men at home. So that's one of my favorite comics so far. So yeah, it's basically adventures in glaucoma over the past 10 years. And I'm going to talk about a couple of things we've been playing with and really focus on these four things, on ab-internal bleb revision, a double muscle speculum, management of tube-associated hypotony, and then a conjunctival pedicle flap for the repair of complex tube erosions. Some of the other stuff I'm not going to talk about, but you can, if you go to my YouTube channel, you can watch some of these videos and other things. You know, but the overlying theme is really, when you're in clinic every day, there's so much we don't understand about ophthalmology, so much we don't understand about glaucoma. And think of if you think of your clinic as your own laboratory, where you're learning every day about the disease. And really, if you're not learning from your patients, you're not paying attention. So they teach us every day if you pay attention. And these are examples of where I think my patients have taught me to be better. And one was using this technique we described back in 2017 with an ab-internal bleb revision. And this is what the spatula looks like. I think it's like $100 or $200. And I can get you the information for the guy who designed it for me. But it's really an 18-millimeter long spatula that has a slight curve, and then the tip is a little blunted. It's a little flat as a blunt with a kind of a sharp side, and you'll see how I use it. And what I do is, this is a left eye. I'm sitting temporal. I make an inferior paracentesis, reach across the anterior chamber. And then here is an upside down view. So this is the superior angle, and that's the sclerotomy site. So I go across the angle, go find the sclerotomy. I go through the sclerotomy, and then I come off the eye with the gonio prism. And here we have the spatula reaching across the anterior chamber, underneath the flap, dissecting posteriorly. And then this thing is just my traction sutures, an atovicral traction suture used to control the eye. And then you just dissect bluntly just the posterior aspect of the flap. And the blue helps you shine through, and you can see where it is, but it's blunt, so it won't perforate through the conjunctiva. And then you see this nice bleb form, and you see a nice posterior bleb form. Now, what's interesting, and I didn't realize this when we were designing this instrument, and when I was thinking about this technique, is that when you're going, you know, some people say, well, why don't you just do a needling at the slit lamp, which is fine. But when you needle at the slit lamp, you go through the conjunctiva, which has blood vessels, and you're more likely to break a blood vessel when you're doing it. Then you break a blood vessel, you get a lot of blood underneath the conjunctiva, and it messes up your view. Through this technique, you're going within the eye, underneath the scleral flap, and you're breaking avascular fibrotic tissue. So tissue that doesn't have any blood vessels. So you're not likely to break any blood vessels. And so you typically just see down to the bottom right of the screen, you see this diffuse bleb without any blood, without any inflammation. And so when do I use it? I do this in a patient that has a scarred flap bleb, maybe an tenon cyst. And a tenon cyst is a different beast than just a scarred bleb. And a tenon cyst, sometimes you can break it with some 27 gauge needle and break it down. Other times it won't work, and then you can kind of go through here. Or I do it in situations where a patient has a failed bleb and I don't want to put in a tube in the eye or anything like that, or do a second trab. Or we all have these cases where a patient has a functioning bleb and everything is great. And then we do a phaco, and then the bleb scars. And then we have to go back in. You can open it up this way. What I typically do is, here it says 1 week prior, but sometimes I even just do it right before the surgery. In the operating room, I'll rotate the globe down and inject mitomycin C. Usually maybe 0.2 of 0.2 mito, so about 40 micrograms of mito. But we're pushing our doses a little bit. But the key is to inject it way far back in the far fornix, away from the limbus, where you're directing flow. So here's a video of it. And in this situation, again, it's a left eye. I'm sitting temporal, and you can see the scarred bleb right up top here. So I'm making an inferior paracentesis. There's the iridectomy. Here I'm using my second instrument. I made 2 paracenteses, but you can also use a traction suture to rotate the globe down. And that's the spatula. It's 18 millimeters long. It's longer than a cyclodialysis spatula, and it's blunter, and it's less likely to perforate. The first time I did this was with a cyclodialysis spatula, but you realize the 18 millimeter length. So here's going through the ostomy right here, and you want to make sure you know where you're going, because you can create an iridodialysis or a cyclodialysis if you're not careful. And you got to flip your brain upside down because you're looking through a gonioprism. And then once you're embedded in there, then I use either the second instrument or a traction suture to rotate the globe down and control the eye. And then here you can see, you're breaking, and you're breaking through the scar tissue. And there's usually 2 kind of rings of steel, or 2 layers of scar tissue. And you can feel yourself going through one, and then you can feel yourself going through the other. And you really want to dissect posterior. And you can see, thankfully the instrument's blue, so you can see the blue shining through the conjunctiva. And I'm just unroofing the posterior aspect of the flap, so you can get that low diffuse posterior bleb, right? So we're working right here. And I always throw a suture in here just in case the pressure goes too low. I put in 2 10-0 nylon sutures, and I'm pumping up the eye and washing out the helon. And then I'm going to put some helon in the eye because the pressure is going to be low, and you want to protect the pressure from going too low. But you can see that nice diffuse posterior bleb. So you want to pressurize the eye, and usually you won't be able to pressurize it too much because you've just opened up a big portion of the flap. But this is what they look like before. And these are the kind of blebs you see afterwards, this nice low diffuse posterior bleb. Really just a nice example of, here's the preoperative bleb flat, and you see the same patient, the postoperative bleb, low diffuse posterior bleb, the blebs we all dream about. And here's an example. This is a patient, he had pigmentary dispersion syndrome. I did a trab on him, it worked great, and then I had to do a cataract surgery. After the cataract surgery, it failed, and I went back in and did this bleb, and now he's back to 11 on no medications. And this is what he looked like at 9 months after the bleb revision. So we reported our outcomes in 21 patients.
Davinder, sorry.
Yes.
When you're doing this technique, you told us that you put in the temporal side, right?
Correct.
Yes, and where do you put your incision? At what hour to have more comfort in this technique? Because it's a difficult position, right?
Yeah, so this is, here, look at C up top. This is a left eye. So I'm sitting temporal right here. My incision is at 6 o'clock, and the bleb is at 12 o'clock.
Mhm.
So I'm going, and you can even go a little inferior. If the patient has a prominent cheekbone, you can go a little bit inferior temporal.
All right.
As long as you, before I make my incision, I throw a gonial prism, I put a gonial prism on the eye, and I look for the ostomy.
Mhm.
And if the ostomy is a little bit superior nasal, right here, then you can make your incision infratemporal and go reach across. If it's right here, sometimes you can go here and you can reach across more temporal, but I like to always know if the patient has a prominent cheekbone, then you have to go more temporal. So you can make your incision more temporal if they have a prominent cheekbone. But in this situation, what I usually do is I make it almost 180 degrees away from the sclerotomy site.
Right. And the mitomycin you're using, like you're putting previews like 1 week prior to this technique?
Yeah, so I used to do that in the exam lane. I would inject 1 week before, but actually I should change that slide. Now I even do it just in the operating room. So right here, this is before I've made any incisions on the eye. I'll rotate the globe down, and then I'll inject as far posterior as possible. Where I know the flap is and where I think I'm going to be directing flow is where I want the mitomycin C to be. And these patients are, I do this as a block, but you can do it topical.
Okay.
And if you do it as a block, then you can just give undiluted mitomycin C, either 0.1 cc's or 0.1 millimeter of 0.4 mito, or you can give 0.2 milliliters of 0.2 mito, which again, the same amount as 40 micrograms. But you can, if it doesn't look that scarred, you can give 20 micrograms. But these patients have already showed that they can scar because they already have scarred once. They've already been given mito because they've had a prior trab. But I like to push at least 40 micrograms, inject at least 40 micrograms of mitomycin C.
All right.
That makes sense?
Yes.
Okay. So let's see. Yeah, so I mean, you can do this in blebs and after, 6 months after trabeculectomy. You can do this even 10 years after trabeculectomy. In this study, the mean age of the bleb was almost 7 years. And we have, by the time we published this study, the patients had almost a year follow-up, but they went from, pressures of 22 and 3.7 meds down to 12 and 0.8 meds. 4 of these eyes went on to need another tube shunt. But you could flip it around and say, well, that's 17 patients where I didn't have to put a tube in the eye, and I was able to open up their old trabeculectomy. And what I like about this technique is, 1, it's successful, but 2, it really helps create that nice bleb morphology, because you're not unroofing the whole flap. You're just unroofing that posterior component of the flap. Intraoperatively, you're going to have low pressure, so I leave some Helon in the eye. I give the patient 1 drop of atropine, and then I give them a subtenon's injection of 40 milligrams of Kenalog, just to really help control inflammation. And then postoperatively, I treat the eye for the first week with the steroids and antibiotics. I usually keep them on atropine once a day or twice a day to prevent them from getting a choroidal, because their pressure is going to be low. And then I keep them on steroids 4 times a day until everything is calmed down, and then I taper it down. But this isn't a new idea. This has been done in the past, and Dick Simmons is one that published this back in the 90s. But what he did was he made a corneal paracentesis right through the mid-peripheral cornea, put in Helon, and then with a cyclodialysis spatula, went through the ostomy and opened it up. What I like about this technique is that sometimes if you make a wound, I don't like making wounds right where the cornea is. Then you have to put a suture into it, leaks, induce a lot of astigmatism. I like coming from below. 2, the spatula that I have is a lot longer, so you can really get that posterior dissection. And then 3, the spatula is flat and blunted, Because if you do a cycloalysis spatula, if the conjunctiva is thin, you can poke right through the conjunctiva. And I've done that before with the cycloalysis spatula. So again, I said, this was my, my morning coffee routine now that with the coronavirus, but some people are suggesting making a different type of coffee called quarantine coffee, which is just like normal coffee, but it has a margarita and no coffee. Anyway, so I'm going to move on to some innovations in tube shunts now. Are there any other questions about the bleb revision?
Yes, they will tell me, let's see, what gonio lens are you using in that technique?
So in this picture, I'm using just a 4-mirror gonio prism, which is autoclavable. But what I've switched to now is actually the Ahmed gonio prism, which is a single lens that can rotate, that Ike Ahmed designed. And it's a little bit higher magnification, but it's not a Sean Jacobs. You need an indirect, you need a prism, not a direct view, because you need to be able to look underneath the, you need to look the opposite way. And you don't, it's harder if you tilt the head. So it's a 4-mirror gonio prism or a 1-mirror indirect gonio prism.
And other question is, for how much time in your experience with this technique, this bleb survive?
So, you know, we've been doing this now for 3 years, and I have patients that are 3 years out, 4 years out that, actually we published it in 17, but I started doing it in 16. So yeah, we have patients that are 3 or 4 years out that we're still working, number one. And then number two, there are patients where it worked, and then 3 years later, 2 years later, it fails, just like a trap will fail. But then I'll go back and do it again. And those patients that I've done that on, they still are continuing to work. Because what I like about this is, again, you get this type of bleb morphology. You don't get the that pale ischemic anterior bleb. You still maintain some nice, healthy vessels at the limbus. You're directing flow posterior. So, you know, these are all patients that have already failed once, so they're at high risk of failing. But I've had really good experience with this, especially the two things that, a couple things we changed from this technique that Dick Simmons was doing was, one, the spatula, and then two, giving more mitomycin C. And I think that's key. Giving more mito at the same time really helps ensure the success rate.
What kind of anesthesia are you using? Like only topic or retro bulbar? Or?
I usually do peribulbar. But that's because at my center, the anesthesiologist block, and so the patient comes in the room already blocked. But you could easily do this. I would say the first time you try it, do it as a block. But the more comfortable you get, you can probably do this topical with some intracameral lidocaine.
Perfect.
All right. And there was a question about whether I tried this at the slit lamp. You know, for the same reason, the problem with the slit lamp I don't like is that when you're going through a needle and you're breaking through, you're coming anterior and you're going through blood vessels to get to the scar tissue, and you kind of sometimes can't see what you're doing, and then you don't have control over the chamber, and if the pressure goes too low, you have a problem. What I like about this is that you can leave Helon in the eye afterwards, number one. Number two, you're going through fibrous tissue that has no blood vessels. So you're less likely to get a bleed. And I think it's a little bit more controlled. And you're less likely to bleed. Okay. So let's talk about now some tube shunts. Now I know you guys do mostly Ahmed valves because the bar belts are very expensive, but
no, here are more expensive the Ahmed than the bar belt.
Oh wow, okay.
Yeah.
Oh wow, okay. Then do you guys have access to Adi, the implant from India?
Actually, I put that now.
Okay, good. Good.
Yeah.
So that's helpful. And then New World Medical has come up with a similar implant called ClearPath. That also, but I bet you nothing's going to be cheaper than the Audi.
Yes, I think so too.
So this is, you know, in the US, we have access to all the different things, Maltinos, Barvelts, and ClearPath, but we don't have access to the Audi.
Mhm.
I had some friends tell me that they did not do Barvelts because they didn't have a proper assistant in the operating room. They operated at a facility where they were just doing a lot of cataract surgeries and they didn't have an assistant to hold the muscles. And so this made me come up with an idea called the double muscle hook. And this is what it looks like, or a double muscle speculum. And it's basically a speculum where you can, if it's open, it looks like this, and then you can squeeze it and then turn the dial, and then it locks it open in place. And it's curved around. This is something my instrument guy made these by hand, but now they're a little bit more natural curved to match the curvature of the globe. And so what you do is you hook the muscle. This is a left eye. You hook the superior and the lateral rectus muscle, and you lock it into place. And then you hand it to your assistant, and then your assistant holds it. And then you have two free hands to put in the tube, and then you're free. And you don't have to depend, anybody can hold it for you. You don't have to have a specific skilled assistant. And you can adjust how wide it opens by squeezing it and turning the dial. And then now you have two hands and you can just insert it. So let's show the video of that. And first, again, I'm isolating the lateral rectus and the superior rectus, so I can see where I'm going. And then I come in with the double muscle speculum, and I hook the superior rectus. And then I'll hook the inferior rectus. And then I'm going to squeeze the top and it expands it. And then you can see my hand come in and I'm going to turn the wheel to expand it and lock it as far as you want it to lock. And then I hand it over to my assistant, and now I have two hands. And then with the muscle speculum, a muscle hook, I put it in one quadrant, and then I put it in the other quadrant. And that's a 350 Barvelt, but the Audi is the same thing.
Yeah, very nice.
And then I undo the wheel, and then come out. And so this I did this because I had friends and colleagues that said they didn't do a Barvelt, and then I always like to test it. They didn't do a Barvelt because they didn't have someone that could help hold the muscles. This is, again, I'm getting all these comics, so I don't know what the phrase of WTF or what the F in Spanish is, but hopefully you guys know what WTF is.
Yes, I know.
It's pretty ubiquitous. So,
hey, Davinder, and what drainage device do you prefer, the Amet or the Verbal?
I do everything. It depends on the patient. Mm-hmm. So I do Ahmeds in patients where the pressure is very high and I need the pressure down immediately. I do it in my uveitis. And then sometimes I'll do it in my older patients that are very old, like 80 or 85, 90 years old, where I just want the pressure down and I don't want to have to worry about it opening or restrictions. But outside of that, I really have switched over purely now to the 250 Barvelt. Or now I do the 250 ClearPath because in the US, the ClearPath is less expensive. But if the Audi was available, I would do the Audi all the time. But what I've changed a lot is now I don't really care about the size anymore. It's the only time that size doesn't matter. But I now do 250s because now if the pressure gets too high afterwards, like we talked about, I think last week, if the pressure gets too high afterwards, then I'll just do a low energy traditional CPC diode or micropulse to lower the pressure to complement the tube. So I'm putting in smaller tubes now because I can now supplement it with if the pressure goes too high, I can supplement it. And getting on to what we talked about, what we're going to talk about next, is what's interesting is the more experience we're getting in tubes, we're running into this problem, which is a tube-related hypotony. So we know that with time and with age, our aqueous production goes down. So the aqueous production of a 25-year-old is greater than the aqueous production of a 60-year-old, which is greater than the aqueous production of an 80-year-old. And so what we're seeing now is we're seeing patients where when they were, 70, even 65, they got a 350 Barville. And now they're 85 and their aqueous production is going down, and now their pressure is too low, and their pressure is 8 on no medications, or 6 on no medications, or 4 on no medications, and they're starting to become a hypotenuse. So that's the reason why I've moved away from the larger tubes as well, because our patient population is living longer, and we're starting to see this problem. So, so let me talk about a way we've come up with of managing this tube-related hypotony.
This is a case of ab-internal flow restriction for tube-related hypotony. Glaucoma drainage implants are becoming more common. Aqueous production decreases.
Let me see if I can mute that. Hold on. There we go. Okay, so we talked about this. This is aqueous production going down as people age. And so here's a patient that was a 76-year-old white female. She had a history of cataract surgery, corneal transplant, SLT, and then she's on max medications. And her vision is 20/50, pressure is 23. She's got a corneal transplant, which is healthy. I put in she comes in with a pressure of 23 on max meds. Nerve is 0.75, so I put in a 350 Barville because she has a transplant. And she's done well. And at 5 months later, her vision was about the same. Her pressure was 11. She was on Timolol once a day and steroids 3 times a day because of the transplant. So I sent her back to her referring ophthalmologist. And then she comes back 2 years later. Her vision's low. She has some corneal edema. Her pressure's 10, and she's just on steroids. And then her husband passed away, and I don't see her again that's why I lost her to follow-up. And then she comes back 2 years later after her husband passed away. Now her vision's 20/80. Her pressure's 4. She's still on steroids. She has macular edema, vitreomacular traction. She has good flow to the plate, but her pressure's 4. And so what are the options, right? You can take out the tube entirely. You can take out the tube and put in a smaller tube. You can trim the plate and then tie it off and start over. But then, I thought, are there any ab-internal options? And so what I did, let's see. This was described out of Korea using multiple 5/0 nylon sutures with an Ahmed. But what I did was I took the patient back to the operating room. This is a 4/0 Proline, very similar to what we do with GAT. I blunted it. This is topical. Through 2 small paracenteses, I put the suture in the eye and cannulated it. And it's like a snake swallowing an egg. You can see I just completely blocked it off entirely. And then I just trimmed it and left it in the eye. So you can see I blunted it. I put in 2 iris hooks because the iris was kind of in the way, and the tube is in the sulcus because she had a PK, a corneal transplant. And then I'm pushing it through the tube, and it's completely occluded. The bulb is so big that it's there's loose, so I'm going to make it bigger. So I made it bigger, and so now you can see it's going to be harder to push in. It's really completely occluding it. And then I go in and I trim the suture. It's not going anywhere because it's so big. It's just stuck in the lumen of the tube. And then I wash everything out. All right.
And do you leave some visco there?
No, I wash it all out because the tube is now completely closed. I use visco to do it, and then I wash out all the visco.
All right.
So I left the operating room feeling pretty proud of myself. I gave myself a pat on the back, and the next day she had a pressure of 40. And then I put her back on everything, and then her pressure ended up being 25 or 30. And then I was remembering why I put the tube in the first place. And so now, what are our options? Same options, right? I can take out the tube. I can replace it with a smaller tube. I can trim the plate, or I can try something again, ab interno. And you guys know I'm going to try something ab interno, obviously.
Yeah.
So now what I did was use a 5-0 proline, and actually, no, sorry, it's still a 4-0 proline, but I blunted it. But I blunted it not so much that it would block off the tube. I just blunted it so it would take up some of the volume of the tube. And look, you can even see it going in right here.
Mm-hmm.
It's going to the plate. So now it's taken up the volume of the tube and made the lumen smaller. But the problem is that now it's just it can fall out, right? So I'm thinking, well, what can I do? What can I do? And so I push it through the wall of the tube. And so now it's stuck in the wall of the tube and won't move. That way I know the tube won't migrate out. And so you can see now this is slit lamp afterwards. You can see that it's it's going up to the plate. It's not blocking the plate. You still see some flow to the plate. And this is what it looks like. The tube is in the sulcus and it's going through the wall of the tube, the suture, and it's holding the suture into place. And her cornea is still clear. Her transplant is still good. And now I'm not worried that the tube is going to come back in the eye. This was over a year ago. She's 14, now she's about 16 months out. But her vision is 20/80, about the same, 20/60, 20/80. Her pressure is now 8, and she's on steroids twice a day. So this was a way for me to address the issue of hypotony, tube-associated hypotony, without having to touch the conjunctiva. And I was able to perform under topical anesthesia without incising the conjunctiva. I was able to kind of titrate it and make the bulb size and the lumen size depending on how much I wanted the pressure to go up. And then I embedded the suture into the wall of the eye, into the wall of the tube, so that it wouldn't move. So that's again a way that our patients are constantly teaching us to be better. And I think the more and more you have experience with tubes, the more you're going to see this problem of tube-associated hypotony. Are there any questions about that?
I were talking about when you put this proline inside of the lumen, proline stay inside?
Yes.
Question. This is a case of ab-internal flow restriction for tube.
I mean, move to the anterior chamber?
Yes. Yeah. The tube
stay there, right?
This is what she looks like 1 year later. These are slit lamp pictures 1 year later. So it stays in this is in the tube going up to the plate. And this is what it looks like this is that slit lamp photograph 1 year later of what the patient looks like.
Perfect.
So now we're going to talk about other problems we're experiencing with tubes. Is these, tubes are typically done in sick patients and eyes that have been through a lot. And so this is management of complex tube erosions. And this is something we published back in 2013, but we've been doing for a while. And the name is kind of long and tenuous, but it's called fornicele, meaning it comes from the fornix, conjunctival, a pedicle flap. And I'm going to define some of these terms. So this is a 63-year-old female with a history of ICE syndrome and thyroid disease and diabetes. She had a corneal transplant, a cataract surgery, a trabeculectomy, and an OMED. And then she presents with a tube erosion in her left eye. She's on bromonidine, timolol, and FML, fluorometholone ophthalmic solution, a mild steroid. She's like, it's an ICE syndrome, so she doesn't see well. Her pressure's decent, but she has extensively scarred conjunctiva and advanced glaucoma. And this is what her OCT looks like. Her right eye, thankfully, as classically you see with ICE, is healthy. But this is what she looks like. This is actually some mascara, but this is the tube erosion right here. You can see all this conjunctiva is scarred down with an old trabeculectomy. Nothing you can do here. And so again, what are the options for repair? You can revise it directly and try to close it, but there's really no conjunctiva. You can take conjunctiva from another area, cut it out, and bring it over and put it on top, an autograft. You can try to cover it with sclera or pericardium and then cover as much as possible and hope that the vessels come through. Or more invasive, you can reposition the tube and, or put one down below inferiorly, or you can take it out entirely and then do a diode or an ECP. But let's take a step back and talk about skin flaps. So we've been learning from our general surgery colleagues, why do we do a skin flap? So a skin flap is used to provide skin coverage in an area, usually in burn patients or plastic surgery, provide skin and coverage to an area that doesn't have skin and doesn't have vascularity. It doesn't have blood vessels. And so you need to understand also the dimensions of a flap. Typically, the proportions based on the plastic surgery literature are 3 to 1. So if your flap is 3 millimeters long, the base should be 1 millimeter. Because you need to make sure that enough blood is going through that flap to help provide vascularity to the distal flap. So the longer it is, the wider it needs to be. And interpolated flap, the word interpolated means that you're not just bringing a flap here and moving it here. You're actually bringing a flap here and moving it to an entirely different area over some healthy tissue. So a pedicle flap is the same thing as a flap. And so you're doing an interpolated flap where you're bringing tissue from a source, bringing it over healthy tissue, and then bringing it somewhere else while still maintaining the attachment. And so, flaps in ophthalmology we use with, a Gunderson flap or a Hughes flap, but we don't use them a lot in glaucoma. But I think one of the reasons why people get tube erosions is because you're not getting proper blood vessel supply to that tissue over the tube. And, I know in Central and South America, they do a lot of the tunnels. They do a lot of scleral tunnels instead of, in the US, we still use a lot of corneal patch grafts or pericardial patch grafts or scleral patch grafts. But regardless of how you cover it, I think the most important part of preventing you from having a tube erosion is the health of the conjunctiva over that area. And if that conjunctiva is healthy and vascularized, I don't think you're going to get an erosion. I think you're at highest risk of getting an erosion when you lose your blood vessels around that area and then the tissue doesn't get healthy. So what I like about this flap technique is you're bringing in healthy tissue, you're bringing in healthy vasculature to an area that has been deprived of blood vessels. And so we got an artist to help us draw it. So what you did was, here's the erosion. We cauterize around it, I suture it. I would actually say now I change my technique a little bit. I actually will pull out the tube and redirect it a little bit to a different area. But I covered it here with corneal patch graft. And then what we do, this is in conjunction with one of my colleagues who's an oculoplastic surgeon, is he double everts the lid to get access to the fornix. And then he cuts a piece of the fornix out while maintaining this base, this flap. And then he rotates it over healthy tissue to the area that needs it. And then I suture it here. And this whole area is still, it's healthy. It's not a symblepharon. It's still healthy and they're still mobile. And actually you can pass a probe underneath here because it's going over it and you still have that. It's not attaching here. It's attaching at the base. So let's show the video.
Demonstrating the use of fornicio-conjunctival pedicle.
So here's that patient with ICE syndrome that I presented. You can see this is the old trab. This is mascara. Really just, it's a lot of scarred tissue. You can't do anything up there, but the patient has some healthy tissue posteriorly. So I'm dissecting around the tube. Making a nice pocket. And then I also like to suture. This is a 90 nylon. I like to suture the tube to the wall of the eye. And this is corneal patch graft. And I'm tucking that cornea in that pocket that I made. And then I'm going to suture it in place. And then my colleague is going to come in, who's the oculoplastic surgeon. And he's going to do things that I've never seen done before, which he double everts the lid and then puts a suture through the tarsus to really provide some good exposure. And then he's mapping out a 3-to-1 ratio of the 1 millimeter or 1 centimeter base. And this is a lidocaine with epi to help control bleeding. And then he's doing a partial thickness flap with a little bit of tenons and conjunctiva from the fornix. And he can do this in his head now. He's done so many. He helped invent this technique. But now we have let me pause it real quick. So now we have, we brought that flap over to the area of defect, and now I'm just lining it up and I'm going to suture it down. And this is atovicral. And again, it doesn't need to be everywhere. You just need to reapproximate it, and then it'll become vascularized and epithelialized. But look at the health of that tissue compared to the surrounding tissue. The blood vessels and the tenons is so much healthier than this area over here, which is the key to success. And this just closes by its own, and you don't get symblepharon or any scarring at all. And so this is what the patient looked like on the first day. Again, it looks like a symblepharon, but it's not a symblepharon. You can actually, if you had a probe, you could pass it underneath this flap. It's not scarred down. You have full mobility. And this is what she looks like on the first day. This is what it looks like on the first month. Again, just this tissue coming from the fornix down over it. Look at those vessels compared to the vessels, no vessels here and the vessels over here. And 4 years later, she's still hand motion, her pressure still controlled, no evidence of erosion at all, and the pedicle flap is still intact. And this is what she looks like. You can't see that anything was done. There's no ptosis or anything like that, and there's no restriction of movement. You can't tell anything was done to the lid at all. And this is what she looks like. Again, nice, healthy, flat conjunctiva with good vasculature. And again, it's not a symblepharon. This is just a flap of tissue coming down. You could still pass a probe underneath here because it's just tissue over a tissue. We have patients that are 10, 15 years out, and these are people that have had multiple surgeries. If you look at our paper, we have a table on the number of surgeries and how long they've lasted. But these are patients that have had 6 or 7 surgeries, scarred conjunctiva. The risk of erosion, when you look at other techniques, is almost 50% recurrence. We don't see that with this. But again, the key thing is making sure that dimension is 3 to 1, and bringing in healthy vessels. Yeah, so this is our paper. We have a third of these patients had diabetes. 15 eyes of 14 patients. 80% had undergone more than 4 prior surgeries, and our mean follow-up time is almost 50 months, and no history of recurrent erosion. But this paper has a chart on every single patient. But we've been doing this now for a very long time and have had tremendous success with it. So, tubes are becoming more common. We're going to start to see complications in these eyes that have been through so much. Tube erosions are a very challenging problem. And when you look at all the other techniques of prior closure or redirecting, none of them bring in healthy tissue to the area. And you can do this in combination with and not all of them need it. If you have enough tissue that you can close it, you don't need to do this. This is only for the most advanced cases where there's a lot of scar tissue and you need to recruit some healthy tissue. And we initially described this actually back in 2003. And then the paper we did in 2013 provided a lot more long-term follow-up. So are there any questions about that?
No, I mean, it's a comment on only that have a lot of sense, because when you put that flap there, the vasculature is still there. So everything became healthy, like you said, right? Because a lot of people would think that you will cut completely that flap and put it there.
It's dead.
Right? But not like this technique.
Exactly. So yeah, when you do the autograft, if you cut the conjunctiva out and you remove it, you've just amputated all of the blood supply, which is the most important thing. So the reason why you get these erosions is you need blood vessels at the limbus, and that's a key part of this technique. So all these.
And there's also a question. What is your recommendation to not touch the Mueller muscle and avoid some diplopia?
You're not touching Mueller's at all. You're only taking tissue from the fornix, the fornix, the forniceal conjunctiva. You're not touching the tarsal conj at all. So it has no impact on the lid movement at all.
Perfect.
So all these instruments, again, I have no financial interest in any of these instruments, but all these instruments are made by this gentleman right here, Mateen Amin, who's helped me design I come up with that crazy idea, and he, helps me put it, and he helps design it, and then he sends it to me, and we work on things. So we have a couple other things in the works that are still coming out, but he helps me design it all. What I like about him is he's a mad scientist. He's very, very smart, and he helps create and improve on these instruments. Number 2, he will donate 6% of sales to our foundation to help us take care of patients and do educational events and things like that. But the other thing I like is in Central and South America, and in India, and in African countries, and in China, he actually doesn't make a profit off of instruments. He sells them essentially at cost. So so he usually upcharges the United States and Europe and Canada, but in other parts of the world, he sells them essentially at cost, or sometimes he sells them at a loss. So he's really been helping me in one, helping me design these instruments, and two, making them accessible around the world in a very affordable way.
Sounds a good deal.
He makes a lot of microsurgical instruments as well. And the ones that are stainless steel, the ones I do with GAT, I think are like $150, $200. The titanium ones are more expensive. I think they're maybe $800 US dollars. But the titanium ones, what I respect about him is that he provides a lifetime warranty. So if they break or bend or have any problems, he'll replace them for free forever. Wow. He won't provide the same warranty with stainless steel, but the stainless steel ones are a lot less expensive. So if you take care of them, they're fine. But you can email him if you have any questions, or email me. I'm happy to help with that. But in conclusion, really, I walk into clinic every day. I try to remember that that the patients, they're trying to teach us about this disease and about what we don't understand. And if you pay attention, you'll learn from them. And if you're not learning something every day from your patients, you're not paying attention. And this is the golden age of glaucoma surgery. We're coming up with newer and more exciting things to do. And sometimes you have to be willing to continually adapt, to try new things, to be uncomfortable in the operating room. And I would say whenever you're in the operating room and you're gonna try something new, ask one of your colleagues, one of your senior colleagues, to come with you. So he or she can be there just thinking and watching while you're in the hot seat. And that's what I do every time I try to come up with something. I have my partner, Ron Feldman, sit next to me. So I'm working and he's thinking, and we always provide something better because of that. And it provides you that safety net to try new things and know that someone is going to be there to help you in case there's a problem. But there are a lot of things you can do now ab interno that don't require having to incise the conjunctiva and thinking about the glaucoma surgery from the inside out. And then, yeah, whenever you're thinking about something crazy, bring in a colleague. So, and don't do what I do. Everything I come up with is reusable and not disposable, and you don't make any money off that. If you want to make money, come up with something disposable. Again, the GOP is our Republican Party in the United States, and who thought that our president got on TV last week and said, "Hey, guess what? Some of you are going to die. It's going to be okay." Hopefully, you guys have a leader that's a little bit better and a little bit more encouraging. But at this point, we think it would be nice to get a briefing from the coronavirus on how it's going to keep us safe from our president. But anyway, this reminds me, I was trying to bring this video up. Let me see if I can do something real quick. The last time I was there, I had the most amazing video, and I wanted to share this with everybody because this was the Copa America 2019. My favorite video. The shootout, 2-2, last kick. So I hope in these times of where things are tough, and what I loved about that is we stopped the entire meeting to watch Peru, the national team, play. And I hope in these times of toughness and fear and concern and worry and sickness and sacrifice, when we're all taking the self-quarantine, that we think of moments like that and we enjoy. This is my son. We put him in his Halloween costume. He was a king. We're going on walks. I know you guys can't go on walks. And this is my wife. She's a pediatric anesthesiologist. This is what she has to wear now to protect herself from corona. But during all these times that we still, take advantage, we stay safe, but we take this time to spend time with our loved ones and our family, and don't forget to laugh, and look back at pictures and memories, and this hopefully will soon all be over. So again, great times down in Paracas. The last time I was in Peru. I'm thinking about you guys all the time, and hopefully you stay safe. And thank you again for this chance to talk and to talk to you guys about some of the fun stuff that we're doing and what we're trying to do. So thank you guys, and let me know if you have any questions.
Hey, thank you very much again, Davinder, for participating in these webinars. I'm sure everyone here is enjoying your talk. We are very happy to have you again, my friend. Thank you very much.
It's my pleasure. It's my pleasure, Juan Carlos. All right.
I ask you about the drainage device because actually from 2009 that I don't use AMET valve because you know all the inflammatory cytokines touch the plate from the first day, so it's more risk for fibrosis. That's why it's a headache for me to put a AMET valve instead of Berbelt or Audi.
Wait, so you only do AMEDs, or you stopped doing AMEDs? I missed it. I'm sorry.
No, I stopped that from 2009. Only put I only put Berbelt.
Okay. So what do you do when the patient has a pressure of 50?
Fenestrations.
Okay.
I do usually 3 fenestration in the tube, and the pressure is 20 always.
Yeah, that's good. I mean, I think it's safer long term because then the tube opens up in a non-inflamed eye. But I feel like sometimes with these bad diabetics and the pressure is so high, with the neovascular glaucoma, I feel like sometimes I don't have a choice. Things I have tried, because I do agree with you. I think that the non-valved implants work better long term than the valved implants. Is sometimes when I do a Barvelt, I'll fenestrate, but sometimes the fenestrations don't work. And then, a week later, 2 weeks later, the pressure's back up to 40 and you're on everything, and you have, you're waiting 2 more weeks before you can open it. Some things what I've done is when I don't want to do an AMED is at the same time, I'll do maybe a hemigat to open up a little bit of the angle at the same time. And sometimes, like we talked about last time, is possibly at the same time doing a CPC or a micropulse, again, to give you that little benefit to lower the pressure while the eye's waiting for the tube to heal.
Yeah. So now we are in a time that we are beginning to mix everything, right?
Yeah.
And for the patient and also for us.
Yeah, I agree. Yeah.
So, ¿alguna pregunta, por favor? ¿Alguien tiene alguna pregunta para el doctor Davinder? Let's see. Do you perform needling in the AMET valve when you have fibrosis?
No, I don't. I would think that if you just needle it, then it would scar back down. But in those situations where you have this fibrotic tissue, the valve is working, but you can see the bleb. In those patients, that's when I do a traditional CPC diode of 1100 milliwatts, 4000 milliseconds, and 30 spots. So I typically would do a diode for them as opposed to anything else.
Yeah, I prefer to do that too. ¿Alguna otra pregunta? Let's see. Only thank you. What else? I have one question. In the moment you are in your AB internal blood revision, have you ever in that moment, instead of mitomycin, in that moment, Avastin, because you have the risk that mitomycin go inside of the anterior chamber?
You're breaking up a little bit. Do I ever do Avastin because of what?
Instead of mitomycin?
Oh, no. Sometimes I'll do both. I do think Avastin is important, and there's an antifibrotic component to Avastin. But with mitomycin C, what I do is before I even do the flap or the revision, I'll rotate the globe down. I'll inject a small amount, 0.1 or 0.4 mito, so 40 micrograms, far back. And then you can wait just a couple minutes.
Mm-hmm.
And then by the time you do your paracentesis, you pump up the eye with Helon, and then you do your revision, and then you irrigate more. That Helon goes out in the subconjunctival space. All the studies that have shown, and we just did a big review on mitomycin C in the Journal of Glaucoma, talks about the binding of mitomycin C. And after about 5 or 10 minutes, it's pretty much all bound and inactive. And so I think what happens is when you're irrigating in the eye and the bleb gets bigger, you're also diluting the mitomycin C. So I think it's a very low risk of refluxing into the eye. And so I think mitomycin C is very important to use. I was initially very cautious, which is why I used to do it 1 week before. So then you pre-treat the area with mito, and then 1 week later you go in the operating room and you do it, and then you don't have to worry about it. But just now, just for patient flow and also safety, because with Zen and with InFocus, even with my trabs, we're getting more and more comfortable injecting mitomycin C. So we're not seeing, we've been doing this technique for about 3 years, 4 years, and we're not seeing any side effects from injecting mito, as long as you make it, as long as you pump up the eye and it dilutes it, and you do it beforehand. But I like Avastin as well. I think they can both be done because I think both are important, especially in these patients. The unique thing about these patients is they've already shown you that they will scar because they've already done it once before. So I think they're at a higher risk of scarring. And so you want to do everything you can to prevent it.
Perfect. So is there other question? ¿Alguna otra pregunta para el doctor Davinder?
Parece que no.
Parece que no, ¿no, Mirel?
Podemos todos entonces abrir los micrófonos para darle un aplauso al doctor Davinder.
Listo.
¡Bravo! ¡Bravo!
Thank you for organizing this. It's always so much fun. And,
Thank you, Dr. Davinder.
I hope you guys will continue to stay safe, and we'll hopefully be in touch soon.
Yeah, of course, Davinder. Thank you very much for.
Thank you so much.
All right, thank you guys. Take care.
We can do something in the future here in Lima. Thank you.
Yes, I hope so. There's more I have. If you ever need anything, we can talk. If you'd like me to do something else, I'm happy to do it.
Yes, of course. Thank you very much.
All right, guys, you be safe. Take care.
Thank you very much, Doc.
My pleasure.
Thank you very much, Davinder.
Thank you.